Welcome to The Explainer. Today we're diving into something that's like the core of what we do as nurses, managing chronic illness. We're going to break down the flow of care, but more importantly, we're getting into the why behind every single thing we do. The clinical rationale that'll help you absolutely nail this stuff on your exams and, of course, in real life with your patients.
All right, so here's how we're going to tackle this. First, we'll get a handle on what chronic illness really is. Then we'll look at the big system we use to manage it. After that, we're going to zoom right in on the family, because they're a huge part of the picture. And finally, we'll get super practical with the communication tools you'll be using every single day. Okay, Section 1, the reality of chronic illness. It really is more than just a diagnosis. To get this right, we've got to start with a really key difference, the difference between the disease and what it's actually like for a person to live with it. Okay, so think of it like this. On one side, you've got the chronic disease. That's the what, the hard science, the pathophysiology, the labs, the medications. But on the other side, and this is so important, you have the chronic illness. That's the who. It's the messy human experience of it all, how it impacts someone's identity, their relationships, their whole life. Now the provider, they're focused on the disease, but you as the nurse, you're treating the illness. You're treating the person's experience. So why do these things even happen in the first place? Well, let's use a visual that'll really stick in your head for your exams. Picture this, a person's genetics, that's like a loaded gun. It's just sitting there. You can't change it. It's not modifiable, right? It just creates the potential for something bad to happen. But here's the thing. A loaded gun doesn't just go off by itself. Something has to pull the trigger. And that trigger? That's everything else. The environment, a person's lifestyle, their daily behaviors. These are all the things that can be changed, the modifiable risk factors. So here's the rationale. This is where you come in. You can't change their genetics. You can't unload that gun. So what do? Your entire focus, everything you do, is on those triggers. Your job is to help the patient essentially lock the trigger so it can't be pulled. And how do you do that? Through education on diet, smoking cessation, stress management, all that good stuff. This is the very essence of primary prevention. All right, let's move on. Section 2, the chronic care model. We're shifting from that old doctor knows best attitude to a real partnership. This is a huge shift in how we think about healthcare. The old way, right? The paternalistic model. It was basically, I'm the doctor, I tell you what to do, and you do it. Simple, but it created passive patients who just waited for instructions. Well, the new chronic care model, it totally flips that on its head. It's all about a partnership between what they call a prepared, proactive practice team, that's us, and an informed, activated patient. So what's the goal here? Well, the whole point is to create productive interactions. And what does that mean? It means we're empowering patients with what we call self-management support. We're using our clinical information systems, the EHR, to be proactive with follow-ups. We're tapping into community resources to fill in the gaps. And the big one, the most important piece of the puzzle, is putting the patient at the absolute center of their own disease management.
Okay, let's make this real. Here's a quick check-off scenario, just like you'd see on a test. Imagine you're in a clinic, and you're looking at the chart for a patient with uncontrolled diabetes.
All right, which of these actions best aligns with that chronic care model we just talked about? Is it A, lecturing the patient on complications to scare them into shape? B, checking their record for a due eye exam and working with them on a diet goal? Or C, just telling the provider to up their insulin because, they're non-compliant?
The answer is B. And let's break down the why, because this is key. Option B uses the Clinical Information System, the EHR, to make sure evidence-based stuff like the eye exam gets done. It shows self-management support because you're collaborating with the patient, not just talking at them. See? That's how you create an activated patient. The other two options, lecturing and blaming, that's just the old, ineffective model we're trying to get away from.
Okay, Section 3. Now we're going to talk about the caregiver, because we have to expand our definition of who actually needs our care. When you're dealing with chronic illness, you'll almost always find what I like to call a hidden patient in the family.
And check this out. This is a pretty staggering statistic. Loneliness is actually twice as harmful to a person's physical health as obesity. Just let that sink in for a second. The social piece is just as important as the physical piece.
And all that pressure, all that stress, it can lead to a formal nursing diagnosis called caregiver burden. And it's exactly what it sounds like. It's the physical, emotional, and financial exhaustion that a family member experiences when they're providing care. And what happens? They start to neglect their own health. This is something you absolutely have to be on the lookout for. Now here's the priority, the safety rationale. Think about it. If the caregiver gets sick and burns out, the patient's entire safety net just disappears. Poof, gone. So your priority nursing intervention is to protect that caregiver. And the number one way we do that, we arrange for respite care. This gives them temporary relief, a chance to breathe, so they can take care of their own health needs before they crash.
All right, section 4, the art of patient coaching. This is where we get really practical. We're moving away from being a lecturer and becoming a true collaborator. Let's talk about the specific techniques you're going to use.
The gold standard for this is a technique called motivational interviewing. And here's the key. It is not about arguing with a patient or lecturing them. It's about asking really good, open-ended questions. Things like, what's the hardest part about this for you? Then you reflect their feelings back to them, like, it sounds like you're really frustrated because... The whole goal is to help them work through their own mixed feelings, their ambivalence, so they can find their own motivation to change. And trust me, their own why is 1,000,000 times more powerful than your you should. Okay, last section, checking for understanding. You've done all this amazing coaching, but how do you know it actually landed? How do you make sure the patient got it? You have to use this one critical safety tool to close that loop.
And that tool is the Teach Back method. Honestly, this should be non-negotiable. It's that important for patient safety. It's super simple. After you explain something, you ask the patient to explain it back to you. But, and this is the most important part, in their own words. And you have to frame it the right way. You say something like, I want to make sure I did a good job explaining this clearly. See? It's a test of your teaching, not their intelligence. That takes all the pressure off them.
Okay, let's lock this in with one last scenario. You're discharging a patient who has heart failure. They have a new diuretic, and you've just explained that they need to weigh themselves every single morning. All right, so which nurse here is actually using the Teach Back method? We've got Nurse A, who asks, do you understand what I just said? Then there's Nurse B, who just hands them a pamphlet and says, here you go. And finally, Nurse C, who asks, so, in your own words, can you tell me what you're going to do tomorrow morning?
And the answer is, of course, Nurse C. Let's look at the why. Asking, do you understand, is a closed question. It just gets you a yes or no, which tells you absolutely nothing. A pamphlet is a great tool, for sure, but it doesn't confirm they can actually apply the information. Nurse C is the only one who is actively verifying that the message got through correctly. That's the core of the method, and it is a proven safety competency.
So if you think about it, we've kind of followed the flow all the way from the microscopic disease out to the whole healthcare system, then zoomed in on the family, and finally right down to the words we use. And the one thing that's clear is that chronic illness is a family affair, right? So I'll leave you with this to chew on. If the patient is really the center of care, how do we need to redesign our systems to truly treat the family as part of the patient?